Then I made that.
Yeah, I think you have to do the duplicate one, so it'll show the same on both.
We all right?
It's working now.
All right. Everyone ready? You ready? I'm ready. All right, well, my name is Kathleen. I am a dietetic intern here with Adagio. I'm originally from San Francisco, California. So winter's been fun. And I went to UC Davis. Today, I'll be talking about pressure ulcers or pressure wounds, which I, before being assigned this topic, didn't realize was so nutritionally linked and so nutritionally related. So it's been really interesting for me learning. I've become kind of an expert in the field because I've been drawn to it with keeping this topic in mind. So any wound fair or wound meeting or anything that was taking place in my hospital rotation, I always wanted to be involved just to be able to see all the different components of it. So what is a pressure ulcer, a pressure wound? It is damage to the skin which is caused by reduced circulation. So usually it's because a bone is pushing against the blood flow and it's preventing blood from circulating properly, and then it results in tissue dying. There's other terms, bed sore, wound. This is just an overview of what the skin looks like, all the different layers. So there's the first layer, the epidermis, dermis, subcutaneous, muscle, then bone. And there's different stages or kind of ways that pressure ulcers are categorized. There's stage 1, 2, 3, 4, then there's unstageable and deep tissue injury or suspected deep tissue injury. So now that we've all had lunch, I'm going to show you some fun pictures of pressure ulcers. We'll go quick. This is a stage 1 wound, so it's just kind of a reddening of the skin. The skin is still intact, and it usually occurs over a bony prominence, which would be like elbow, your coccyx, tailbone area. This is a stage 2 where the wound is open. It could either present as the top picture, which is an open wound, or as kind of like a bloody blister almost. So that's the bottom one. This is a stage 3. And so this is where the subcutaneous fat would be visible. You won't see bone or muscle yet, but just the subcutaneous fat. And then it depends on the location of the wound, because some areas have deeper tissue. If it's in the ears, usually caused by the nasal oxygen being administered, then it could be still a stage 3 just because of the number of layers it's penetrating, but it won't be as deep just because that skin isn't as deep. And then here's a stage 4, which is, you can see that there's bone visible, there's muscle, there's tendons, everything in there, and you could honestly touch the tailbone in this one. So, yeah, you're welcome. I was cringing on Google Images as I was looking at all of these. This is an unstageable wound, and it's unstageable because there is a dark eschar or slough that has kind of formed in order to protect the wound, but in doing so, we can't see how deep it penetrates. And so in order to properly be able to stage it, it needs to be debrided. and that slough needs to be removed, and that will also help with, it'll promote wound healing. And then this is a suspected deep tissue injury. This is just kind of a dark reddening under the skin. The skin's still intact though. And something else I learned about pressure ulcers in my time is that I thought it occurred over long periods of time, usually because you're bedridden, but there was a patient in the hospital that I'm working at who she developed a deep tissue injury in just a matter of the time that she was in the ER, just waiting for a couple hours, and she developed a pressure wound. And it was because, I'll go through the risk factors, but she met all the other risk factors as well, so her tissue was just in a really poor state. This is etiology, so it's just the blood flow being pinched off because of the muscle or the bone kind of digging into the blood flow. So here's risk factors. This puts somebody at a higher risk of developing a pressure ulcer. Usually it's found in the elderly. There is some data on adolescents and children with pressure ulcers, but it's usually because they have a lot of these same risk factors. They're immobile because of spina bifida or cerebral palsy or something else. So immobility is one of them. Comorbidities that are associated with decreased blood flow. So diabetes, COPD, poor nutrition, either due to dehydration or dysphagia, so that often occurs in the elderly. If you're 70 or older, then you're also at a higher risk of developing a pressure ulcer because your skin isn't as elastic and you usually have lost a little bit of the subcutaneous fat that would help kind of cushion the bone and prevent it from cutting off blood flow. Incontinence, and then impaired mental status. And the impaired mental status is a lot of times it contributes to the dysphagia or because of the poor nutrition. If someone has impaired mental status, they're usually not eating properly because they're not remembering to and such. So this is nutrition-related risk factors: poor PO intake, poor fluid intake, substance abuse, and then significant weight loss also puts somebody at high risk. These are some of the coding and billing associated with pressure ulcer care in the hospital. But what was interesting to learn was as of 2008, Medicare and Medicaid will no longer reimburse hospitals for pressure ulcers that are developed during their care in the hospital or in the home. And pressure wounds are very expensive to care for. It's estimated that they cost either 9 to 11 billion per year in the U.S. And so if that's not reimbursed for a hospital, each wound costs about $43,000 per hospital stay. And so if a hospital isn't being reimbursed for that, then that could make a serious dent in their bottom line. So prevention is the main key. And MNT for pressure wounds. So if you have a patient that does have a pressure ulcer, you would want to, they have increased nutrient requirement. So it'd be 30 to 35 calories per kilogram. If they're underweight or malnourished, it would be increased to 35 to 40. And then protein is increased as well, anywhere between 1.2 to 1.8 grams of protein per kilogram. And I saw even up to 2.1, but with that is the risk for dehydration. So 1.8 is a good meeting point. 30 to 35 for fluid, and then possible supplementation with vitamins A, C, and E, zinc, and then the amino acids, arginine and glutamine, because they promote kind of tissue regeneration. These are my references. So let's take a look at my patient. This is Mr. S. He was admitted to Trinity in Steubenville, which is where I'm doing my hospital rotation. He's a 72-year-old male. He's divorced with 4 children. He's a retired steel worker from the Wheeling Pittsburgh Steel Corporation, and he lives in a nursing home called the Laurels. He's been there since 2009. He doesn't smoke, but he did. He doesn't drink, and he is a Methodist. Like my picture? He was admitted for being unresponsive, fever, chills, temperature, and he is 70 inches before, so once we go to his past medical history. He had bilateral above the knee amputation, so he doesn't have really most of his legs. He has some edema and a stage 4 wound on his coccyx with a wound back. So here's his past medical history. He's had a stroke, pneumonia, hypertension. He had his amputations, coronary artery disease. You can see the list goes on. And if we were to kind of categorize, going back to those risk factors, pretty much fits into every single one of the risk factors. So he's immobile due to his amputation. His stroke has left him with a little residual paralysis. He has hypertension, COPD, type 2 diabetes, peripheral vascular disease. He's malnourished, or he's at least undernourished because likely due to his Alzheimer's, schizophrenia. He's over 70 and impaired mental status. These are his current medications. Some of his lab values. I highlighted some of the ones that were out of the normal range. You can see his glucose is above average. His CRP is elevated, so that could indicate inflammation. His liver enzymes are elevated as well. And his prealbumin is really low, so that's another indication of malnutrition. His average blood glucose was 187, so it's not very well controlled. And he's currently being fed via PEG tube. So he's getting Oxypa at 60 mLs an hour with every 4 hours a 300 ml flush. So that would provide about 31 calories per kilogram, 1.9 grams of protein per kilogram, and then 35 milliliters of water. And that fits in with the recommendations that were listed previously from the Nutrition Care Manual. He does not ambulate, so he's immobile. He hasn't since 2010. He's disoriented. He's also sedated and intubated. During his hospital stay, they were attempting to insert a trach, but he wasn't cardiovascularly stable enough, so they were going to wait for him to kind of stabilize before doing that. And he's sedated on Diprovan, which is suspended in a fat solution, so that also provides calories. So we have to keep that in mind when calculating his total nutrients. And then he's got a PEG tube. This is his weight history. It's kind of, it's been consistent over the past few months, but you can see kind of back in 2009 when he was ambulating, he was much heavier, he was much more nourished, and then he had some moderate to severe muscle and fat wasting. This is my nutrition diagnosis for Mr. S. Malnutrition related to an acute illness as evidenced by loss of muscle mass, and then a stage 4 wound with a wound vac. And has anyone seen a wound vac or had any experience with them? So the purpose of a wound vac is to kind of close off the wound and remove any excess fluid in order to promote blood flow, to promote healing. And so that's usually seen in the more severe cases, just like this stage 4. You usually don't see it in like a stage 1, 2, or maybe even 3. I've only seen them with stage 4s. And he has increased protein for wound healing. So recommendation would be to keep his Oxypa at 60 mLs per hour because that was meeting his nutrient needs, and then obtain CRP in order to see how his inflammation is doing, if it's going down. In the medical records, it looked like the doctor thought he had osteomyelitis, which was like an inflammation in the bone, in the tailbone, likely because of the exposure to everything because of the open area. And then continue Prostat, which is a nice big source of, or boost of proteins, 15 grams of protein per little packet, and that was being administered through the 2 feet as well. He was getting that 3 times a day for an additional 45 grams of protein. So monitor the Diprivan rate to see if we need to adjust his needs at all because of the fat. Check for triglycerides. Sometimes if patients have really elevated triglycerides, then they'll consider a different method of sedation. Monitor his tolerance of the tube feed, so making sure he doesn't have any distension or diarrhea. Monitoring signs of dehydration and also signs of wound healing. The goals would be tolerance of the tube feed, no signs of dehydration, maintaining a stable weight status, so trying not to have any increase or decrease, and signs of wound healing prior to discharge. So all in all, preventing pressure ulcers is the main goal, and that requires a multidisciplinary team. So it definitely requires the cooperation of the nursing staff, making sure that a patient who can't ambulate is moved frequently so that there's no one area that has more pressure on it, which would put the patient at higher risk of developing an ulcer. And then also making sure that the patient is nourished, that there isn't skin breakdown to begin with, and that would be the dietitian's part. So if there is a patient that you notice that has those risk factors, maybe suggesting Prostat or Juven, which also have, yeah. Oh, sorry, I thought you. And then, yeah, just making sure that everybody is working together to prevent the ulcers. Anyone have any questions? Yes.
I have just a couple of questions.
Yeah.
When you talk about the money for wounds and that, remember there's cost and there's charge. So
Okay.
that's what the hospital is charging to make them well, but that's not necessarily, and probably is not the cost, so there's a
Okay.
big difference there. And with the wound vac, do you think that would affect his nutrition in any way?
I think it might affect his hydration status if it's removing fluid
Well,
from the
yeah, but
wound.
it doesn't remove that much fluid.
Okay.
But what's it removing?
Protein? So
So
supplement
you
with
need to boost
additional
the
protein.
up here. And the last question is, how would you adjust his weight, since he doesn't have?
You would
either
use
leg?
the calculation for the bilateral. Well, you could either use his height that he is now, or you could use the calculation to, it's, I think, some percentage, 9%.
For each.
So it'd be 18.
Well, no, it's more than 18, because it's the front, it's the leg and the leg, it's 2, and then the leg and the leg.
Okay.
So you'd have he says a significant reduction, so you would just need to calculate that difference, but he's not getting that much 72 feeding for that weight because they're not there.
But then he has really increased needs too
Oh,
because
he
of
does.
the wound and
He
everything. So it actually kind of evened out.
Three questions. One is, because I didn't see it on the slide and I can't read it on this. What was his hemoglobin A1C before?
I didn't, let's see, I have his lab values up here. I know that at my hospital, a lot of times that's not on his, let's see. I don't know if that was tested, the hemoglobin
Okay, it's very
A1C.
important
Mhm.
part, because wound healing, if someone has a hemoglobin A1C in the tens, forget about it. It ain't gonna heal until you get the diabetes under control.
Yeah.
If it's 108, you got a shot, very good shot. So it was a very significant piece of information. Second one is what, and this comes from practical wisdom, why do you care about triglycerides? The status of this person, this is practical wisdom questions, why do you care?
In his condition of his heart and
Yeah, why do we care?
because if there's atherosclerosis or anything, then the blood won't be able to circulate as efficiently or
The
as
key word is
effectively.
practical wisdom.
Okay.
In his circumstances, do you really think triglycerides are gonna take him out?
Probably not. Yeah.
And the third was, this just comes up because it asks you on physician presence in infancy, childhood, and adolescence. What would you do if this was an infant?
Well, generally it's with an infant, there would be a a reason why the infant is immobilized or
Why
what.
might that be?
Well, spina bifida was one that I found, or if they have paralysis, if they have cerebral palsy, some other kind of neurological condition where they can't control their muscles or their body, so that they're in one position, they can't move around. And the nutrients would be definitely elevated in order to promote wound healing, but I don't know the exact breakdown per kilogram.
Okay, I don't need to know that, but the other would be trauma.
Mm-hmm.
Someone who took their kid home, they were told to keep this leg elevated, it's in a cast and don't move it. Underneath that cast, the wound is serious, down to the bone, and it happens. Young skin, it shouldn't happen.
Yeah, especially if they're
It will
malnourished to
never
begin with.
heal again.
Just one question, do you know what's probably the biggest cause of, I don't think you discussed it, the biggest cause of ulcers?
Of pressure ulcers,
Well, our first one is bedbound,
probably diabetes.
it's many times just the sheer pulling of sheets and things.
Yeah, it's a
So-
combination of
Yeah, so that's
yeah.
one of the biggest causes of.
pressure ulcers. Carol?
Great, thank you for that, it was a wonderful presentation. I'd like to know, do you know what the prognosis is for that person? It says here something's wound healing prior to discharge. Do you think that's gonna happen anytime soon? That's just a professional judgment. I can't answer that myself. Okay.
To be honest, I know that he was discharged and he's at a long-term, like a LTAC, long-term acute care facility right now. But he, with stage 3 and 4, they often don't really heal. With stage 1 and 2, you have more of a chance for them to heal, but 3 and 4, once it breaks the skin and is open like that, then maybe you can have a little bit of wound healing, but it's never gonna fully close up again, especially with all the other comorbidities that he has going on.
Thank you.
Tell me why you would recommend to obtain the CRP and the AM. Can you expand on that a little more?
So the CRP was elevated in the previous labs, and that would be a sign of inflammation. And so seeing if maybe his inflammation is going down, the osteomyelitis was a concern. So seeing if maybe because Oxypa has some anti-inflammatory fats in it, so seeing if the wound healing or inflammation is going down because of the nutrition we're providing, or what else needs to happen. Maybe inflammation is causing other conditions and we need to start a steroid or something.
And in the AM, does it matter really?
I don't think it matters. That's just when blood is drawn at Trinity. Yeah.
Okay, I wanted to see if there's anything special behind that part of it too.
No, yeah, it was more just the time of day that the phlebotomists go around.
Sounds good, thank you.
All right, well, thank you.
So everybody would complete their evaluations and pass them to the center of the room this evening. You can collect something. Yes, please note, good point, please note there's to turn the page over.
Sorry,
I didn't
Yeah. That's what I did.
Is it like those black?
Did
You get the black screen.
Here, don't do anything.
My name's Chrissy. We're talking about HIV/AIDS today. Before I wanted to get started, I did want to thank Lenore. She actually helped me get this patient for my case study and really helped with some of the information. So thank you, Lenore.
It's not fair.
So just the basics, I'm hoping we have some kind of knowledge about HIV and AIDS. But HIV is human immunodeficiency virus. It's the virus that causes AIDS. And AIDS is when the body can no longer fight off infection. The immune system is so down, our CD4 T cells are depleted, and someone has an opportunistic infection. I'll talk about that a little bit later, but that's kind of when the immune system is so down and another infection comes in, and that's when we start to get really sick. Just some facts throughout the United States and globally. I mean, you can read these, but 35 million people worldwide are currently living with HIV or AIDS. It's a huge epidemic. 3.2 million children are living with HIV, so it really affects people not only physically but emotionally. It's not the easiest disease. This just kind of gives you the breakdown between some different countries. As you can see, Sub-Saharan Africa, 24.7 million. The United States, North America, and Western and Central Europe, 2.3 million. But it's really affecting that area in Africa is where we see, some of those pictures where people are just kind of wasting away, is what you might think of when you think of AIDS. Just some more stats. White males who have sex with males, that is the number one. Most people that pass the disease on are those white males who have sex with males. Infancy, childhood, and adolescence. This is important for my patient, but yes, this disease is seen in infancy, childhood, and adolescence. In infants, the virus can be transferred if the mother is positive. It can be transferred through just pregnancy, through a vaginal childbirth, or through breastfeeding. The mother should be tested no matter what, even if you think, I don't have it, or I do. And you can receive treatment to lessen the chances that your child will have HIV. So if you don't receive treatment, there's a 25% chance of passing the virus to the baby. And then if the infant does have the virus, 20% will acquire an opportunistic infection within their first year of life. So that's a big statistic. Within childhood, most of the children have been infected through pregnancy, childbirth, or breastfeeding. And then adolescents, about 1/7 of all new HIV infections occur at this time. So that's kind of a lot. The teens are becoming more sexually active, so it spreads throughout that age. Just some common billing codes. Yes, you can be reimbursed for different aspects of HIV and AIDS. The pathophysiology, I did give you guys a little handout. You can see some of the pathway of the virus a little bit more if you care to look. But really what's important about the pathophysiology is that some of the treatment for this disease, or actually all of the treatment for this disease, targets a different point in this life cycle of the virus. So when we get different drugs, they disrupt the virus from going, completely through the pathway. Risk factors in transmission, it's the bodily fluids. Be blood, semen, microfluids, breast milk, any kind of sex, sharing needles and syringes, Healthcare professionals sometimes can be infected if they work with someone who is HIV positive, they get stuck with a needle or something like that. And then contact between broken skin, wounds, and mucous membranes sometimes transfer the virus as well. So, just some signs and symptoms between HIV and AIDS. HIV can be very asymptomatic. People sometimes mistake it for mono. You know, fever, fatigue, and this acute retroviral syndrome can be shown within 1 to 4 weeks of infection. It can last maybe 2 weeks. The clinical latency, this is where the virus is living and developing in the body, but we may not show any signs or symptoms. The antiretroviral therapy, the ART treatment, helps to keep the virus in check. If you are receiving treatment, you could be fine for many decades. But if not, you know, we could start to show different signs or be infected with another disease, maybe for 10 years. So AIDS, this is when the CD4, the immune system, the count drops below 200 and these symptoms start to worsen. We see different AIDS-defining illnesses develop. So I do have an opportunistic infection handout for you too. You can see some of the different diseases that infect HIV-positive individuals. But this is the rapid weight loss, night sweats, sores of the mouth, anus, genitals, pneumonia, neurological disorders. Usually, I guess sometimes in the African areas or less developed countries, people do start to waste away. They lose their appetite, they have different aversions to medication, they don't feel well, they don't want to eat, and that's when they start to lose the weight. Just some testing. This ELISA, Western blot, antibody test, any kind of test that we do receive, if it's positive, we want to do another test just to make sure. There are some mix-ups sometimes. Labs with an HIV-infected individual, really the two that count the most are the CD4 count and the viral load. The CD4 count, like I said, is the immune system function. The lower it drops, the worse the individual is becoming. And the viral load is how much HIV is in the blood. Other labs you might want to test for just how well the body is doing if you have another infection coming in. You just want to see if the body is healthy. Treatment, there is currently no cure for HIV/AIDS. But like I said, there are different drugs that we can take, sometimes known as the cocktail, antiretrovirals, heart-to-heart therapy. And the goal really, like I said, is to find different combinations of these drugs that target the virus pathway and to lessen the side effects. So side effects of the medications, you can see anemia, fatigue, headaches, nausea, vomiting, things like that. So we want to lessen those. Just some ongoing concerns of this disease. There is resistance to some medications. If, you know, when the medications can't stop the HIV from replicating through that life cycle. The opportunistic infections, we want to keep the body as healthy as possible to prevent other infections from really bringing the immune system down. Transmission and prevention, you know, safe sex, just not passing the disease on as much as we have in the past, and awareness. So just a medical nutrition therapy, really it is about good nutrition, at least in more developed areas, lessening the symptoms, medication, and just preventing these opportunistic infections from bringing the body down. So just maintaining a healthy weight, eating fruits and vegetables, all that good stuff. Another thing is educating individuals on eating safe food. So these foodborne illnesses may affect an HIV positive individual more than someone who isn't affected. Okay, so my patient. She's a 42-year-old white female. She's currently a stay-at-home mom, and her husband works. She does not drink any alcohol, stopped smoking 3 years ago, and she has 2 children, 13 and 19. She has a family history of diabetes and heart disease. Her weight is around 215 right now. She's 5'10". So a little bit about her background. She was diagnosed with bipolar disorder at age 15. She's had some emotional distress throughout her years of becoming diagnosed with HIV. And she's been a type 2 diabetic for about a year, since May 2014. So a little bit about her diagnosis. She was actually fine for a long time. And her first daughter was born, no complications. She actually did not have an HIV test. And then when she was pregnant with her second child, she actually did get an HIV test. The results were not shared with her. I'm not sure why, but they were not shared with her. Her daughter was born, no complications with the childbirth. And then her daughter started having complications at about 3 or 4 months. She was diagnosed with pneumonia 3 times, went back to the hospital at about 8 months, went back to the hospital at 11 months. Her daughter started having neurological problems, and they finally took an HIV test on the daughter and my patient, both positive. Her other older daughter, not positive, and her husband, not positive. So she's not quite sure how she got it. Is that correct?
She's pretty sure how she got it.
Was it?
Sexual assault.
Okay, that's what I thought. So she was sexually assaulted a number of years before her first pregnancy.
Before she was even married.
Yes. So just a lot of,
No, but I mean, she was assaulted before she even had a husband. So she did not.
so her daughter, who is HIV positive, has neurological problems, damage to her extremities, has a number of various contraptions, wheelchairs, everything. So that's why my patient stays at home. She takes care of her daughter now. That is her job. And I actually went to her home and saw everything. Her daughter is doing fantastic. She does karate, she does cyber school. It's kind of very, very amazing. But there has been a lot of guilt and everything that's gone along with that. So just some of her medications, Truvada and Eisentrust for HIV. She's on Wellbutrin for an antidepressant, and Genuine for type 2 diabetes, and Lipitor for cholesterol. So we did get a chance to talk about her diet a little bit. She loves to cook, she loves food, she loves to eat a lot, and she is aware that she eats too much. But she has made some changes recently. She switched to diet, Mountain Dew. She uses olive oil spray, and some of her portions are somewhat smaller. So just some of her labs, her BMI is 30.8, but she has lost about 30 pounds since her diagnosis of diabetes last spring. I did check up with her a couple weeks ago, and she said she's continuing to lose some weight, so that's very good. Just some labs. I chose about 4 different episodes, episodes for her. She was in the hospital in August 2013 with severe respiratory distress, and she was diagnosed with pneumocystitis pneumonia. She was diagnosed with AIDS. Her viral load was 79,000, very, very high. And her CD4 range was 2 to 17, so almost hardly even there. She had stopped her medication, so that's why this happened. And since then, she did have another episode, but she told me that it's kind of like a family thing now. Her family is threatening her. She's never allowed to stop her medication again, so she's really in on that now. But then a month later, after that first episode, her viral load was down to 32, so fantastic. And then, as you can see, May 2014, when she was diagnosed with diabetes, her A1C was 6.7. So just kind of a little bit of overview. Her second daughter with neurological damage. She suffered a lot of guilt, like I said, but she's learning to cope now, and she is taking medications. So just some two PES statements that I came up with. Overweight related to beliefs about nutrition and food beverages, as evidenced by a BMI of 30.8, and excessive oral food beverage intake related to desires to eat unhealthy and easy food to please children, as evidenced by large portion sizes, BMI, and ideal body weight percentage. She does like to make food that's simple and easy for her family. When I was there, she did order pizza for her and her daughter. So kind of like the intervention, I did just suggest maybe, making some vegetables or fruit as a side with that pizza, side salad, something like that. Just small, steady changes with her, I think will go a long way. So just a little bit of weight loss, and to choose 2 more fruits and vegetables per day were just 2 of our goals that we talked about. Monitoring and evaluation, I followed up with her a couple weeks ago, just to see how she was doing. Like I said, she's lost about 30 pounds in a year, and she's continuing to do that. She's choosing more fruits and vegetables, and she is controlling her diabetes now. She's taking her medications, doing pretty well. Any questions? Yes.
I have 2. Do you know if her weight loss is intentional or is it the disease process?
No, she wants to lose weight. She knows that the diabetes is her main concern right now, so she does want to lose weight.
And was the second child a C-section or a vaginal delivery?
It was vaginal.
And did she tell anyone she had AIDS?
She didn't know.
Oh, at that time she didn't?
Yeah.
She
She
didn't
was
know
not-
until they diagnosed her.
Yeah.
She had no idea. I mean, people think that they're okay, they're not okay.
They didn't follow up?
Did great follow-up, she was not told the results.
Yeah, I don't know
That's
why.
if she figured no one was good, she had no idea. Imagine the horror.
Chrissy, how can they explain the fact that one daughter has it, the other one does, or one child has it, the other one doesn't, and the husband doesn't?
Mhm. It is a little
Obviously,
bit,
that's big to get,
yeah.
at least plus.
It is a little bit confusing, but it's not always passed to the child.
Or the father.
Yes. So I guess chances were just on her side, the first child, and
Can I help you?
yeah.
Okay, I'm gonna explain to you that when it's an intern for the training. The vagina is a very tough cookie, and it is not unusual for someone to be exposed to the HIV virus in traditional sexual intercourse and not spread that virus. That's why more men have it than women. And it is very common. Someone could be positive for as much as 15 years and find out 15 years later, 15 years, and they were given blood and find out they were positive. They could be married, and they could have their wife negative, let's say it's a guy, their wife negative, and all their children happily negative. It is very, very common. What happens is it destroys families because the partner doesn't believe that that person had no bloody idea, because they don't know where they were in high school and who they were with. That's why people think that they're okay. You may not be okay. And that's so, she was sexually assaulted and it never occurred to her. And no one ever suggested to her.
So when you're on the drug treatment, can you still transmit HIV?
It just lessens your chances. Yeah.
Does she have insurance and does that cover her medications?
I believe she does. I don't know if it covers everything, but these are extremely expensive medications, so anything.
What I didn't share with you is she got the age waiver, and state of Pennsylvania and many other states have something called the AIDS waiver. And under medical assistance, if you have a diagnosis of AIDS, which she does, she qualifies for multiple services that someone else would because of the diagnosis of AIDS, not HIV positive, AIDS.
And do you know if the refugees that are coming from the African countries, coming to the United States, is it mandatory testing for them for HIV?
I don't know.
Yes. The answer is yes. Okay, because I haven't heard that.
Yes,
For the
the answer is
Congolese
yes.
population. That's why I'm surprised to
The
hear.
answer is yes. Those that are coming in legally, the answer is yes. They have the multiple, not just one, two.
Is that all adults and all children?
Mm-hmm.
Another thing I did find, actually, there was a new, I don't know if you know about this, Lenore, but there was a new app on the iPhone that was just discovered that you can actually test for HIV in the finger. It's only $35, so they think that this might be a way to decrease some of the spread of HIV and AIDS.
So how do they do that?
I don't really know. Some researchers from Columbia University, and they made this app, so it's pretty
And
amazing.
they're gonna be offering that, I read about that, they're gonna be offering that as a health care, just like you would go and get anything else tested. You can opt for that also. Yeah, you're absolutely right.
Will that app be able to be used on infants and children, adolescents, and adults?
I would assume so. Kind of just like a prick, like a diabetes prick. So yeah, I would hope.
The app would probably tell you about it, right? Because you couldn't
Yeah.
test it on the phone, you kind of do it.
Yeah.
Infants won't
It's like a-
necessarily show positive until they're like 6 months of age on the test.
I'm not following the app.
It's like there's an app and then there's something you have to add to the phone in order to
That
test.
makes more
that,
sense
yeah.
to me. Okay.
Yeah, it's only $35.
Thank you, Kristen.
You can go to a Dodger Health and get it for free.
Thank you. Very displays. Yeah. Alright, so I'm gonna get started. I'm Kaylee Ulrich, and I'm a Dodger Health intern, and I'm from the Pittsburgh area, so not far from here. And my topic is multiple sclerosis, and the kind of cool thing that my first rotation was at Forbes Hospital, and on the first day, I interacted with a patient that had MS, but I wasn't prepared for my case study with it, but then I found one in the middle of my rotation also. And I really didn't know much about it, so this is kind of brand new to me too. Alright, so multiple sclerosis involves an immune mediated response in which an abnormal response of the body's immune system is directly against the central nervous system. And then the central nervous system, as we know, is the brain, spinal cord, and the optic nerves. And it is shown to be more common in women than men, 2 times more common. And it's usually diagnosed between the age of 20 and 40, but I did see some cases around 15. But I didn't see any much lower than that, like in infancy and children and adolescents, like 15, I guess that's it, adolescents, but I didn't see it as common in there. And then it's estimated that 250,000 to 300, I'm sorry, there should be another 0. 350,000 people in the U.S. currently are diagnosed with MS. and its approximate 200 new cases are diagnosed each week. And then here's just a diagram of the central nervous system. So the brain, spinal cord, optic nerve. And then here is a map of the entire United States. So the ones that are in more red are more common to have MS cases. And some of the risk factors that I did see, I kind of talked about some of them, but the age was 15 to 60 and more common in women, like I said before. And then family history, if the parents or a sibling does have it, it's more common. And then for race, I found that North European was more common. And then for climates, I guess it depends on the climate as well. So if you have like a moderate climate, that's more common there. And then also if you have other autoimmune diseases. And then smoking is also a risk factor. And then there is 4 types of MS. So there's relapsing, remitting MS. There's secondary progressive MS, primary progressive MS, and progressive relapsing MS. So the first one, relapsing remitting, is the most common, and it is characterized by clear defined attacks of worsening neurological functions. And they also have relapses or flare-ups followed by partial or complete recovery periods. So there's times that they don't see anything occurring, which my patient had. And then there was secondary progressive, and it follows after relapsing remitting disease course, and it has periods of remission, and the disease will begin to progress or become more steadily. And then the third one is primary progressive MS, and it's a steadily worsening of the functioning without any relapse or periods of remission. And then the last one is progressive relapsing MS, and it's the least common. And it's the steadily worsening of the function from the beginning in addition to occasional relapsing. So what causes multiple sclerosis? It's the damage to the myelin sheath, the protective layer of the outer of the surrounding nerve cells, and the signals begin to slow down or stop, and the damage is caused by inflammation, and it occurs when the body's own immune system attacks the nervous system, and as I said before, it occurs in the brain, optic nerves, and the spinal cord. And it can be due to a virus, a gene defect, both, or what's going around them. And then here's just a picture of the myelin sheath and how it's affected. And then some of the signs and symptoms, it really depends on the location, the severity, and each attack can be completely different. It can last days, weeks, or months, and it can be followed by remission. And then also, fevers, hot baths, sun exposure, and stress can also be shown to worsen the attacks. And that was seen in my patient. He was under a lot of stress. So some of his attacks would come when he was under the stress as well. And then it's common for it to occur again and return through relapses. And then as I'll talk about, there's so many signs and symptoms, and MS can affect so many different parts of your body. So here's some of the muscle symptoms, such as loss of balance, muscle spasms, problems with walking. And then the ways that can affect your eye is double vision, eye discomfort. And then for the brain and nerves, it can do depression, hearing loss, poor judgment, attention span can be affected. And then for your bowel and bladder, it can affect your constipation and bowel leakage, urine leakage. And then for numbness and pain and tingling, it can affect facial pain, painful muscle spasms, and then tingling and crawling sensations in your arms and legs. And it also can affect the speech and swallowing. So some cases they have difficulty they can have a hard time understanding their speech. They have a trouble with swallowing and chewing their food. And then also fatigue is shown throughout MS. And I thought it was interesting that it is worsened in the late afternoon, too.
So this is just a diagram of how MS can affect all parts of your body. Okay, for the diagnosis, it has an exam of the of the nervous system, and this can show reduced nerve function in one area or multiple parts of the body. And this can include abnormal nerve reflexes, decreased ability to move one part of the body or other parts of the body, decreased or abnormal sensations, or a loss of the nervous system functioning. Okay, so for diagnosis, an eye examination could be done to look for the pupils to see if they're abnormal, and also changes in vision fields or eye movements. And then rapid eye movements are triggered when the eye moves. All right, so for tests that diagnose MS, there's a couple. There's the blood test to rule out other conditions that could be similar. The spinal tap, MRI scan of the brain and of the spine, and then the nerve function test. So here's a picture of the spinal tap. Then also here's a picture of the MRI. Okay, so for treatment, there is no cure at this time, but the treatment is more focused on decreasing or slowing down the disease, and also controlling the signs and symptoms, and also for them to maintain a quality life. And then medications are taken long-term with MS to help slow the disease, and steroids can be used to decrease the severity. And also there's a lot of different types of treatments, so there's different types of therapies, there are assisted devices if needed. The person I saw in the beginning, they were in assisted device, but the second one was not. He was actually walking. He was a little slow with walking, but he could walk. There's exercise programs, and then nutrition is also very important, and to help to get relaxation and avoiding fatigue and stress when possible. And then changes in the diet could also be needed too. When I was looking up the nutrition for MS, it was pretty basic. It just said overall healthy diet, decreasing saturated fat and total fat, and not as much fried foods, fruits, vegetables, whole grains. And then also limiting alcohol as much as possible, and smoking. And then possible vitamin D and other supplements was suggested as well, but I put that you should always consult a doctor before trying that. And then one of the newer treatments available is electrical stimulation psychotherapy. And I didn't really know much about this, but the device actually runs for $5,000 to $6,000. And it is a safe, activity-based rehabilitation. And they put these different electrodes in, like, around the body, and they generate complex motor behaviors. And some insurances cover the cost while others do not, so it's important to always consult your insurance company. So there are some medications for the relapses, and these include Solomedrol, high doses of oral Deltasone, and then the ACTH gel. And then for the billing, I got this off of Forbes Hospital, so their billing code for multiple sclerosis is $340 for reimbursement. And then that's just a case study. Okay, so my patient, he was a white male and he was 85 years old, and he had MS for over 30 years. And during these 30 years, he would have relapses where he'd be completely fine, and then he would have times where it was severe. But when I was with him, he wasn't having anything going on. He was in the hospital for ascites and osteomyelitis, and his sons were by his bed constantly because he was very confused the entire time. He would know, I think I saw him for a total of 4 times, and one day he would know who I was, and then one day he would think I was a doctor and would tell me to leave. But he was very confused even during mealtime. So his sons were at his bedside constantly trying to talk with doctors. Okay, so for his condition, I did do a brief overview of what the two diagnosis were. And ascites is the infection in the intervertebral disc space that affects different age groups, and it usually occurs post-surgery. And some of the signs and symptoms are severe back pain, lack of mobility, and low-grade infection. And then also for the diagnosis is an MRI, X-ray, and CT scan. And some of the treatment is antibiotics, back brace, or a plaster cast. And then for osteomyelitis, it's an infection in the bone, and the infection can reach a bone by traveling through the bloodstream. And it can also begin if the bone itself has an injury and exposes the bone to germs. And some of the signs and symptoms include fever or chills, being weak and pain in the area of infection, and swelling and warmth and reddening of the area. And then for diagnosis, it would be blood tests, X-rays, CT scans, and MRI. And then, of course, like the treatment, antibiotics, draining of the affected area, depending on the type. Okay, so for my patient, he is 5'8", and he is 83 kilograms, which is 183 pounds. His BMI was 27.82. His ideal body weight is 70 kilograms. So he has 118% ideal body weight, so just a little bit above. And then his temperature was 98.2, his pulse was 85, and his blood pressure was 120/65. And then here is his medical and surgery conditions, so hypertension, dementia, edema, multiple sclerosis, stroke, kidney stones, neuropathy, muscle weakness, difficulty walking. And then here's his medications that are prior to admission. And then when looking at his risk, he has a risk for AFib, chronic UTI, hypocalcemia, and hypercalcemia off and on, hypotensive.
Read that again.
Did I say it wrong? Hypocalcemia? Yeah, sorry. Hypo and hyper, off and on, hypertensive, and anemia. Okay, so for his medical and health status, he has dementia, quickly forgets a lot, is confused, and is a fall risk considered at the hospital. His occupation was he was a Vietnam veteran, he's retired, and he lives in a skilled nursing facility. And his income is through Social Security, and he has no cultural needs. They didn't really say much about his background. He's had no tobacco or alcohol usage throughout his life. And then for his diet history, he has no known allergies. He has 2 cups of coffee a day, and he had a general diet prior to admission with 3 meals a day. And then the diet that was ordered while his hospital stay was general. He was eating very little, around 25%, and he was refusing breakfast, eating lunch, and then refusing or eating very little at dinner. But he did really like his soup. So every day, if they gave him soup, he would eat everything of it. And he would forget to eat, and there was an unknown weight loss noted, and it didn't say exactly why, and I asked his family, they weren't sure either, but I was thinking, if he's not eating much in the hospital, he might not be eating much at the skilled facility either, so that's maybe what I think it was. And also, he was in pain and forgetting. Okay, so for his physical and clinical conditions, his skin was intact, he had pain from arthritis, he had a hunchback, and then he had MS for 30 years with relapses and flare-ups. And then I calculated his needs, so his energy would be 2,075 to 2,578 kilocalories, and then his fluid would be 2,075 to 2,578 milliliters. And then for his fat, it would be 69 to 86 grams. And then carbohydrates, it would be 260 to 322 grams. And then protein, 70 to 84. And I use these based off the hospital requirements at Forbes. And then here are his labs, and I indicated which ones were high and which ones were low. I have them for 4 days. And then the high bun could be due to a kidney injury or a disease that is present, and antibiotics and diuretics can also increase the BUN, And then for glucose, it could be Lipitor can increase glucose and an infection could be present and under stress. And then for chloride, it could be from kidney failure or kidney disorder or also from the diuretic. And then the low calcium I put for the vitamin D deficiency and possible renal failure. And for the hemoglobin, for anemia and then kidney disease, and then the CO2 for diarrhea and kidney disease possible. And then those are his medications he was on. And then some of them, like Arcept is for the memory and mental function for MS, and then for vitamin D is shown to help with management of MS, and Neurontin is for the management of the pain in MS. And then for my PES statements, I did two. I did inadequate oral food and beverage intake related to decreased appetite and dementia as evidenced by decreased PO and meal refusal. And then altered nutrition related lab values related to stress response as evidenced by elevated glucose levels at values. So the plan was to calculate the patient's needs, which I showed you, obtain more information from the son, and the patient refused the supplement I suggested, but the son was like, please, let's just try anything. So we actually did order a supplement, and to make sure monitor all the daily lab values, make sure his weight is done. And then also to keep talking to his son for more information, I did obtain his contact information. It's important for family support, and I did decide to add an Ensure pudding for breakfast and Ensure Plus for dinner. And then for to monitor his PO intake, the supplement acceptance, the weight, the daily lab values, and then the follow-up with his son upon discharge, a week, 2 weeks, a month, and 3 months, which I did want to do that, but he actually didn't answer my phone call, so I did leave a message. And then for measuring the percent of the meals that the patient consumes, and also of the supplement. And then for outcomes, I put a PO of 75% or greater at each meal, and then for oral supplement, I did 50%. And then that's all questions. Does anybody have any questions? Okay.
What's one condition, looking at some of the lab values, like especially the BUN and the glucose, and what might you suggest, what might jump into your mind?
Well,
as
they
a
kept saying that
diagnosis?
he would there's something wrong with like his renal functions. I know they kept saying that, and they were stressing about that in his, like the notes. They were saying stuff about his renal function.
But they didn't draw creatinine, did they?
No, they didn't draw A1C or creatinine, no.
But what might pop into your mind? I didn't see it as a diagnosis, but a lot of times we think of dehydration. Remember we talked
okay.
about if lab values are percents, then you want to have enough fluid.
Okay, yeah, and he wasn't getting much fluid in him either now that I think about it. It was really hard to get much of anything in him, and since he was forgetting a lot of things, people would try to remind him of things or remind him to eat, and then he would just get really hostile about it. Even they had to do an alert on him when I was there because he was getting out of control with one of the doctors, like screaming at him and trying to like grab him.
So how's a way you can get fluids into him very easily?
During what?
What's one way you can get fluids into him very easily? What does he really like?
Soup, yeah. So they would try to do soup for breakfast. They were trying soup for breakfast, trying soup for dinner, just trying to like get anything in him. I know it's probably not the most nutritious, but it was better than anything.
But it can be. Would you add the Ensure?
Yeah,
Could you
that's
add the
true.
Ensure to the soup and make it a cream
That's
soup?
true, yeah. And they did have they had like a protein thickener at the hospital, so maybe they could even
If he
add
doesn't want
something.
it thick.
Oh
he
yeah, it
wants
wasn't really thick,
He
it
wants
was
it soupy.
yeah.
So add the Ensure instead of milk.
That was a smart idea, yeah. I don't even know if it was meat, it was milk. It was like a chicken noodle, but I mean, you could always.
You try. It's something
Yeah.
different. He likes something hot, he likes something cold. How can you tell the difference between initially, I don't expect you to know this, but I'm gonna ask anyway. 'cause somebody might know. Between MS and Parkinson's.
That's true. Yeah.
Because the diagnosis, I mean, the
They're very
symptoms are so
similar.
similar.
Yeah. They're very
The
similar.
gate's very different though.
What did you say?
So the gate is very
So the
different.
shuffling, it says it has a allergic. Okay.
you think you'll see many 85-year-old persons with MS?
No, not,
And what's something they could have contributed to his MS?
well, he didn't have family history and he didn't smoke.
What did he do when he was a young man?
Oh, he was in,
Vietnam.
yeah, that's
Wait a
true.
minute, I got
forget
an
about
issue with that. Doing the time and doing the math, he would have been, in 1965, he would have been 36 years old in Vietnam.
Mhm.
So that would have been before Agent Orange. So I'm not really sure, he would be more likely the age to be in the Korean War.
That's what
Because
his
when
son
John-
said.
I know,
Yeah.
when Johnson was president, people were not on the ground fighting. It wasn't until
Okay.
Nixon was in 68, which means this person would have been 38 years old. The timestamp doesn't count for Agent Orange.
Could be if he was a career.
If he was career,
If he was
but
career
he's
and
not getting career benefits, he's just getting social security.
I don't know that.
Yeah, so
But
that's what I was
would be
saying,
my-
like, the
If he was,
True.
is he career service, do you know that?
I
And you
don't-
said he was in Vietnam, but
I don't know.
is
I
that
didn't
his
ask.
profession?
It was like when he was younger, and then I know he wasn't really working.
it's just,
Yeah.
the issue being is that there are special benefits for Vietnam
Mhm.
vets for being in country. You had to been in country for Agent Orange. MS, neurological disorders, heart disease, diabetes, there are specific benefits for that. The timeline for him for 85 is more like
Yeah.
Korean War unless he was life military. If he was life military, then there would be some other significant things in there.
Yeah, I'm not sure I
There's a
completely
gap.
understand
Just
that.
note to self, folks, Vietnam vets are eligible for certain things. Generally, they're gonna be in their 60s and 70s. It would be an unusual event for someone in their 80s when you think Korean War came first.
So if
And
they did,
likely Korean.
But his good friend is 78, just got benefits,
Right, so if they were career,
and he wasn't.
yeah,
He just had to.
so it is
It is
possible.
possible.
so if they're not career, then would he still get any like benefits out of his
Well, I would
security?
just say,
He's
unless
saying
he
he
was
was
in
there
the country.
Because he's in the country, yes.
You have
Okay.
to be in
You can't be on a
country.
boat.
You can't be on a boat, you can't be during the Vietnam War out on Guam or the Philippines doing
Or Georgia
stuff.
Tech.
Yeah, you had to have been in country.
Because you wouldn't have been exposed to it.
Yeah.
It's got a huge number of diagnoses.
Yeah, my fiance was over in Afghanistan for a while, and you should see all this stuff. He had all these shots and everything, just because there's so much stuff over there too. You could possibly get. It's crazy. Does anyone else have any questions? Sorry, I know the last was kind of quick. So I had to do this for Forbes Hospital and it had to be a 40-minute presentation, and I didn't want to take too much out.
Marilyn.
Oh, thanks. Thanks. I started rushing.
Hey Deb. Hey Deb.
Okay. It's okay if I walk.
This printer's free, right? Yeah, let me know.
Yeah, yeah.
didn't want to eat too much. Yeah. You said you wanted one, right?
There's usually something John has to plug in. And then try the volume of the line.
In celiac,
Everybody ready?
Now we are.
I'm gonna alternate them.
Or you woke anybody up who was sleepy.
Just check the vote.
in celiac,
Okay, that's good.
Oh, we're not?
Why would we grade ourselves?
Hi everyone, for those of you that don't know me, my name is Rachel Fagerston, and I'm going to be discussing celiac disease with you today. So celiac disease, as many of you already know, is an autoimmune disorder where the body attacks the small intestines in response to the ingestion of gluten. The immune response then leads to damage of the villi, which line the walls of the small intestines. I do have a video here for you, as you just saw. It would be more so geared towards your participants or future clients than it would be for other health professionals. So basically, it's very simplistic, but I like that, so I'll just take a peek at it real quick.
in celiac disease, a protein in wheat, barley, and rye called gluten triggers destruction of tiny hair-like protrusions called villi in the small intestine. Normally, villi allow vitamins, minerals, and other nutrients to be absorbed through the wall of the small intestine into the bloodstream. In celiac disease, gluten triggers the immune system to damage or destroy the villi. Instead of being absorbed, fats, proteins, minerals, and vitamins are eliminated in the stool. Decreased absorption of nutrients, or malabsorption, can cause malnutrition and other long-term problems.
And that's it. Okay. So, what is gluten? Gluten is a broad term used to identify a group of proteins called prolamins, and this chart shows the division, starting with the family to subfamily of grasses until you get down to the bottom here where you can see the relationship between wheat, rye, and barley, which is where we would find gluten. And then of course we've all heard recently how oats are now acceptable in a gluten-free diet. And you would think they might be problematic because they are related by a subfamily, so it's suggested that patients just now look to make sure the products they're purchasing are gluten-free oats and not just oats. And then the risk factors for the disease, celiac disease is genetically inherited, so as you can see by these statistics, 95% have one change in the HLA-DQ2, which is the human leukocyte antigen. while the remaining 5% of those with celiac disease have a different variation of HOA. And even though celiac patients all have some type of variation within their genes, 30 to 35% of the general population also have these variations, so it's not guaranteed that you have celiac disease if you have the variation in your gene. Other risk factors you can see here are having type 1 diabetes, thyroid disease, and again at the bottom you can see the level of risk associated with having a relative because it is an inherited disease. And then patients with Turner syndrome and Down syndrome also have an increased risk, but that's only if they have type 1 diabetes in conjunction with those diseases or syndromes. Celiac disease may seem like something that's new and suddenly been diagnosed in everybody, when in fact it's more likely that our testing has just improved over the last 50 years or so. And we all learned about a study that they did with a bunch of military men at the Warren Air Base 50 years ago, where they took about 9,000 men's blood samples and matched them to men nowadays, and they found that actually it's 4 times more common now for men of that age group to have celiac than it was back then. So it's also possible that the grains have changed, because there's no way that our immune system and our reaction to those grains would have changed in that short amount of time. Normal physiology, we did get a pretty good idea in the video. So you can see in these photographs, the top 2 up here, so an endoscope and then a biopsy of small bowel, you can see that villi are present. Those are little arm-like projections, and that's what would absorb the nutrients in our food. And then at the bottom, you can see this patient with celiac doesn't have those anymore, so there's been atrophy of the villi in the intestines. And over there, you can see with the arrows, small, in the crypts of the intestine, they become damaged and show scalloping, and that decreases the amount of absorption that can take place. So also this is a picture of the normal physiology and how the folds within our intestinal walls and the villi allow for more surface area to absorb as much nutrients as possible. And with celiac patients, that surface area is greatly decreased by the crypts being malformed and the decrease of villi. So they do suffer from malabsorption from that, or malnutrition from that. The pathophysiology of this disorder, it gets very technical, but in a easy description of it, having a genetic disposition and in combination with environmental triggers, when a patient ingests gluten, their immune system just identifies gluten as harmful to the body and attacks the gluten, and thereby attacking their own tissue as well. It's also recently been theorized that gliadin, which is the glycoprotein in gluten, is itself directly toxic to the enterocytes of our intestines. So just eating gluten for some people, the actual protein in that can damage it, not necessarily just the immune response or just the ingestion. So here I just did a little chart so you can see the steps. So you're exposed to it, your immune system responds, this sets off certain triggers in the body and transformations of proteins, which then triggers your T lymphocytes. And here you see this is where the genetic change in some people's body is triggered, so that's where that comes into play. And then what actually damages your intestines is released, and then you have atrophy of the villi. Diagnosing celiac disease is a multi-step process. You can't just do one or the other. It starts with a blood test, and as you can see here, we have the TGIGA, which is the tissue transglutamase test, and that's actually the most commonly used right now because it's extremely sensitive, it's about 95% accurate, and it's very cheap. Next step in the process of diagnosing celiac disease would be to do an endoscopy and have a histology report compiled. So with that, you'd be able to see atrophy of the villi and the crypt hyperplasia, which would be evident in this next slide that I have here. You can see how the changing of the lay of the land in the intestines would be for someone that has celiac versus someone that doesn't. And a Marsh scale is used, with 0 meaning having no signs of disease and 4 is complete atrophy. So using the blood test in combination with a biopsy, you would then diagnose someone. Usually, someone with celiac has a Marsh scale of 2 or 3. Signs and symptoms of the disease are split into a couple different categories. So we have gastrointestinal, non-gastrointestinal, and then there's also some patients that present with rash on their body, which you can see here. And typically, most people would present with one kind of symptom or another, but there are people, about 38% of the population, that show no signs or symptoms, or they're not diagnosed for many, many years. Celiac disease in infants and children, there is a classic presentation, which you can see represented over here with failure to thrive, short stature, malnutrition, diarrhea, things of that nature. And then there's also neurological and psychiatric disorders which are presented, and that's very closely linked to their malabsorption, malnutrition, so they will have deficiencies in vitamins and minerals during critical periods of growth in their life, and often will present with some kind of neurological abnormality. In a recent study that I found of over 300 children, 111 of which had celiac disease, 50% of the subjects that had celiac disease as a child had a neurological symptom, where that's not as common as in adults. Celiac disease in teens and adults. You can see here I broke it down into several different categories. Most of these we are familiar with. The long-standing disease will also present with profound deficiencies such as vitamin D, resulting in rickets or hypocalcemia, and they may also develop anemia secondary to iron and folate deficiencies. It's important also here to recognize that misdiagnosis is very popular in this age group. They can go years and years suffering from what might be assumed to be irritable bowel syndrome or rheumatoid arthritis, because the symptoms do mimic one another in both disease states. And then the most common symptom for adults is diarrhea. Oh. How do I get that back?
The display setting at the top.
It's gone.
Oh.
Sorry, technical difficulties. Okay, so medical nutrition therapy, as you can see here, should be centered around the strict avoidance of gluten in their diets. Some people have said, and I know we have a intern here that is on a gluten-free diet for celiac disease, some people have stated that they shouldn't use any makeup or hair products or skin products that contain gluten. That's very debated from what I understand. Possibly foundation or lipstick should be avoided because they can lick their lips and then ingest it. But outside of that, it's mostly only gluten that is present in the intestinal tract, so you don't necessarily need to use products that are otherwise gluten-free. We should always assess the biochemical data, so looking at their anemia profiles, vitamin profile, mineral, lipid, electrolytes, so on and so forth, and then start medical nutrition therapy addressing those factors first. Like I said again, with the central goal being to eliminate all gluten-containing foods from the diet, making sure that they do receive a balanced diet. My patient was a very happy, healthy, 91-year-old white female. She was of average height, average weight. Her ideal body weight was in acceptable range. Her medical history, obviously she has celiac disease. She also was diagnosed with a casein allergy when she was diagnosed with celiac disease at the age of 87. So she went quite a long time without being aware of her condition. She also has hypothyroidism, pernicious anemia, hyponatremia, arthritis, had a hysterectomy, hypotension, and has spinal stenosis. She has no history of any tobacco, alcohol, or legal drugs. Her socioeconomic standing is good. There's no issues there. Retired nurse. She was never married, does not have any children, and because of that, she voluntarily went into an assisted living center where she lives now, so she doesn't have any medical reasons to be in an assisted living center or anything like that. She's just working on the what if something happens to me. I don't have any relatives that live close by and no children to take care of her. She was wrongly diagnosed with rheumatoid arthritis about 30 or 40 years ago. And we did speak earlier about how it can be linked, they have similar signs and symptoms. And she actually noticed that when she started the gluten-free diet at the young age of 87, most of her arthritic pain had decreased greatly. She also has hypothyroidism, which is something, as I discussed in the risks, being relevant. Someone having an autoimmune disorder is often more likely to develop a second autoimmune disorder. And then her pernicious anemia, she did state that several other brothers and sisters had that as well. And I didn't ask her about it, but thought, did you ever maybe suggest that any of them get tested for celiac disease? Because that could be closely related to that condition because she's not absorbing the B12 the way she should be because the intrinsic factor might be missing in her gut. For the nutrition care process, since she is at the assisted living center, her dietary intake and meals are all very closely monitored. She's on a low sodium diet because she does have slightly elevated blood pressure. Gluten-free and casein-free, as I had discussed, she has allergies with casein. I figured out her energy, protein, and fluid goals if you're interested. She eats well, but says the portions that they serve are too large for her. She eats about half of them, has a healthy intake of snacks between meals, water and juice. She's very health conscious and well educated in her dietary restrictions because she is a retired nurse, as I had mentioned. She is able to drive herself to the store. She still has a car there. She told me her favorite place to go is Trader Joe's. And I looked in her cabinet and everything she has is very expensive, gluten-free, labeled so I don't really find that she has any issues with obtaining foods that she needs that meet her dietary restrictions. Again, here the food availability, we just talked about that. Her labs, there weren't, for her age and what you would imagine to see in someone's lab work like that, she actually was great. As you can see here, just a few of them were slightly elevated, and I would venture to say her BUN and her creatinine were elevated, slight dehydration possibly. She has no medical history of having any issues that would cause those to be elevated. Her B12 was very high. This was actually done, her lab work was back in September, and she had been taking supplements prior to this test, so they stopped them because she doesn't need to have the B12 level that high. And then again, she does have high blood pressure, 143/92. She told me she doesn't like taking that medication, so what she'll do is right before a doctor's appointment, she'll load up on it and see what it does. I didn't get into that with her, so, yep. Anthropometric data, we had recently, or we already touched on that. No issues with dentition or her physical appearance whatsoever. She does enjoy exercise. Like I said, she's single, no children, retired nurse. Her medications, she takes her medications for thyroid disease, her blood pressure, and then a variety of vitamins, minerals, and other supplements that she chooses to take on her own. That's all that she's prescribed. It was difficult for me to find a problem in coming up with a PES statement for this patient, so I just wrote a list of stuff that could be used for someone that has celiac disease. And what I did end up coming up with was predicted suboptimal intake of calcium and vitamin D, possibly related to her casein allergy, because she does have to follow then a lactose-free diet. And then coding and reimbursement for her specific situation, we have at the bottom. For intervention, I would just encourage the patient to continue to consume supplements daily as directed by her physician to help meet her needs given her dietary limitations. Provide continued comprehensive nutrition education, dietary management of celiac disease and a casein allergy. And I would provide the patient with information to give to the assisted living center so that they can help prevent cross-contamination since her food is being prepared in a large kitchen. For monitoring and evaluation, the patient will be directed to read all labels on packaged foods to meet her restrictions, discuss food options with the facility, if possible, to bring a 3-day diet record to register a dietitian for nutrition adequacy review at follow-up. And I would recommend that she go bi-weekly, monthly, and then as needed to ensure that she was meeting all of her nutrition needs with her limited diet, and for her to weigh herself weekly, and then weekly, or as directed by the physician to ensure weight is maintained. Thank you. Any questions? Linda.
Do you think, and this is just an observation, I don't have any statistics, but do you think most people have the blood test that defines celiac disease, or do you think it's not very commonly done?
No, from the research that I had found, and talking with other people, it's not commonly done. They first look to see if you have a relative, either first degree or second degree relative, and then they move on to things like the blood test.
But a lot of people are given that diagnosis, and the
Yeah.
doctor tells them the wheat bread instead of the white bread. I mean, they really don't. I think it's an easy diagnosis, but it's
Yeah.
very expensive diagnosis.
Yes.
And I would have encouraged you to talk to her about taking the medication. About not taking it and then taking it when she goes. I say, what are you're going to the doctor to find out how things are.
Yeah.
So that, you lost a good chance to do some teaching.
She's a funny little lady. I like her.
Oh, yeah, and she knows. but
She knows what she's,
Yeah, but I think sometimes you have to try to make them just gently, and try to make them, and then if they can't justify, they might think about it.
Right.
Who does her shopping?
She does. She does. She has a car on campus, and she drives herself to the store, the Trader Joe's, and picks out everything that she wants.
Where's her located, where she stays?
Gee, where was that?
Head with us,
Oh, yes.
Oh,
Westminster, yeah.
And you
Yeah.
have a little slide on here on dental abnormalities.
Yes.
She has all her own teeth.
Yeah.
Tell me, if you kind of glossed over that, if you just tell me what that means. I mean, what,
I would venture to say that it's from vitamin and mineral deficiency, that the teeth will start to pit and groove because they're not, yeah.
but not for her, because she has her own.
She didn't have any, I didn't notice any of the signs or symptoms in her.
So she was magic.
One more question.
Yes.
Oats doesn't really have gluten in it, but why is it oftentimes eliminated from the diet?
From what I understand, it's because it is so closely related in that chart that I had shown you, how they divide up the grasses and grains and whatnot, that it, from what I learned, that it would be assumed to have the same proteins in it.
You know another reason they might?
I don't.
Contamination.
Oh, okay.
That's the biggest reason.
biggest thing, and it's been well proved that you can actually buy oats that are 100% guaranteed,
Gluten-free? And they're not.
gluten-free, never been kissed by a mouse that ran through the wheat field.
And just real quickly, I did provide a couple handouts, and the one I did like because it talked about basically celiac disease being a fad and why it isn't a fad, it's more of a medical condition. And then the other one that I liked was an article about breastfeeding and how they're finding it has no effect on whether the child develops a celiac allergy or.
Do you have
Is
to watch
any
mom's,
feeding or?
you have to watch mom's diet when she's breastfeeding if she has a child?
According to this, no. They were saying it makes no difference when the child's introduced to gluten, whether the child was breastfed. I mean, this is only one study. I have interest in that area of nutrition, so that to me kind of caught my eye, because I always found that it was more important.
Mom, you talk about gluten-free mothers breastfeeding or just any mother?
They said both, like whether you breastfeed or not, this article says doesn't really matter, and if the mom introduced gluten to the baby or not didn't make a difference in her diet or in the baby's, when the child would present. Yes.
Does gluten transfer through breastfeeding?
I don't think so, but I have no idea. Yeah,
And this is a Linda type question.
yes.
Yeah.
I'm nervous.
Yeah, don't be nervous, you probably don't know the answer.
That's
either.
okay, we can go with that.
Asians, those that are Asian
Mhm.
and within the Asian culture probably don't have a high incidence
Right.
of celiac disease. However, Asian Americans is what I'm curious about. If there's a genetic tendency, is it only because Asians don't have wheat, barley, oats?
Mhm.
Or is it something that is genetically human?
That's a good question, I don't know the answer
Room's
to that.
quiet.
Does anybody have an idea? I'll look into it.
I would bet you it's American food.
But I'm just,
I don't know.
Well, and
I
it's,
would
it's
say.
similar to with these soldiers that obviously their bodies didn't change that much in 50 years. Something in the food product changed in 50 years that made them not able
yeah,
to
so
tolerate it.
Asians in general,
Because they didn't
because
know the
they're
damn
not
rice.
exposed to it,
Right. Anybody else?
wouldn't necessarily mean that they weren't likely to get it.
I was just wondering if you ran into any information as far as like the number of people who like self-diagnose with
I did.
celiac
I
disease?
did.
No.
I'm sure it's high.
Yeah.
100%.
I guess I don't know how you would like find that information,
Yeah.
you know, like, but yeah, I wasn't sure.
Because
Okay.
they don't go to a doctor.
Yeah, exactly, that's what I mean, they,
But
you wouldn't be able to like gather that, right?
And they say that you shouldn't start taking anything out of your diet until after you're tested and diagnosed because that can skew the results
Yeah.
of anything that the doctor might find.
Yeah, one of the young ladies that I work with has celiac, was diagnosed. She said the best thing about it is that you can buy gluten-free food everywhere.
Yeah. Yeah,
That's
because
the
it
best
is so
thing that's happened
popular
for
now as a
disease.
fad.
But you don't need it, eat Asian, you're all good.
Thank you. You, good job.
Alright, hi, my name is Carrie and I'm presenting on peptic ulcer disease. So,
Oh, at the top it's display,
this display.
and then do duplicate.
Thank you. Alright. Okay, so first off, peptic ulcers are,
We can't hear you.
okay, sorry. Peptic ulcers are open sores. They're usually developing on the inside lining of like your stomach. It could be your esophagus or like your upper portion of your small intestine, like your duodenum area. It's shown that usually you have an infection with the Heliobacter pylori. And then you can see the numbers, 90%. The duodenal ulcers are caused by that. And then a little bit less, 60 to 70% are from the gastric. Also, the use of NSAIDs, aspirin and Advil is typical types of drugs. They're really prone to cause ulcers as well. And a couple other medications, potassium supplements, biphosphates. So those are all they're all linked to causing the ulcers. Okay, so common signs and symptoms, abdominal pain, that's actually the most common one. It's usually what the people will present with. Back pain, some of them, it depends on the ulcer. You can have pain when you're awakened, like when you first wake up. You can have pain when you eat something. Pain could come back after you eat, like 2 to 3 hours later. It kind of depends on the different ulcer. Indigestion, heartburn, vomiting, nausea, and anemia. Okay, these are some common risk factors: smoking, drinking, having a family history of the ulcers. Age, actually people who are a little bit older, 60 to 65, are at a higher risk of developing these ulcers. Having diabetes, you can increase your risk of having the H. pylori, so that'll put you at a higher risk of having these ulcers as well. And chronic pain, so if you're a frequent NSAID user, then you might have more of a chance of developing the ulcers as well. Alright, this is the pathophys. I want to do a little diagram so you can see the scale is tipped. So normally in a healthy person that has no peptic ulcers, it would be balanced. Because your normal gastric your acid secretion would be level with the mucosal, like your defenses in your body. So everything on the left, they're all the bad things. They would cause the ulcers. Extra acid, the pepsin, use of the NSAIDs, and being infected with the H. pylori. And then everything on the right, the bicarb. So these are all things that your body would produce to kind of break down the acid or to increase the lining of the mucus to help with, the acids in your body from the food. Or if you have, more of one thing, then it would just be tips. So that's kind of what's showing. It's off balance, so that's why the person will have peptic ulcer disease. A couple other good factors would be epithelial renewal, and some other aggressors, which will be on the left-hand side, would be like alcohol and bile salts. So they would kind of be bad. So for the condition present, it's actually very rare in infancy. It's a little bit more prevalent in childhood. It's still fairly rare. So you can see it's usually common if you have a family history of peptic ulcers. The main causes are the H. pylori, being infected with it, use of NSAIDs, and then stressful events. So actually in adolescence, it's more common, and they're usually linked to the H. pylori, being infected with that. So if you're infected with it from H. pylori or using NSAIDs, then you have primary. And then if you're secondary is if it's caused from a stressful event, developing an ulcer from that. And then adults are the most prevalent. I said 60 to 65 years of age, a little bit older. They're the most frequent people that would have the ulcers. And usually, so you can see there's the 500,000 cases every year, 4 million reoccurrences yearly, and it's about, in the US, approximately 10% of the population will develop a duodenal ulcer at some point in their life. So that's kind of scary. All right, so for the MNT, it's important to have the high fiber diets of fruits and vegetables, good foods that contain the flavonoids, so they'll help to decrease the growth of the H. pylori virus. Vitamin A rich foods. You want to, of course, avoid alcohol, caffeine, coffee and drinks that have caffeine, chocolate, and to try to eat, or at least, a couple hours before you're going to go to sleep, because you don't want to be laying down. You want to be just kind of sitting up and eating slowly. So at least 2 hours before you go to bed. Probiotics are helpful. If you smoke, quit smoking. And a couple of these bottom ones are just, they kind of help with the symptoms of the disease. Trying to reduce stress, maybe pick up some relaxation techniques, drinking lots of good water, 6 to 8 glasses a day, regular exercise, and then there's a document at the very end, Appendix A, you can refer to as well. Okay, so treatment, of course you want to try to get rid of the H. pylori. Antibiotics are good, and usually they'll be in combination with the proton pump inhibitors. So they'll kind of help, there's actually no single cure for this, or no single drug cure for the infection, but you can kind of pair the two, and usually it'll help with decreasing the ulcers and kind of having them heal. So you want to, of course, reduce the gastric acidity. These are a couple of the drugs that would help with that. The proton pump inhibitors, the histamine antagonists, and the antacids. Kind of get rid of the acid in the stomach, the extra acid that you're supposed to be producing. And then mucosal protective drugs, for example, this sucralfate, which my patient actually did take on her first admission, but she doesn't take it later on. So that one's good with helping these for active ulcers and to help prevent previous ones from reoccurring. And there are also some surgeries that can help. They're not as common. Usually they would have one to reduce the acid secretion, and then they would have one to help with the gastric drainage. So they have a couple different ones that they would recommend for the various. If you have a duodenal ulcer, if you have a gastric ulcer, it would depend on that. And of course, stopping with the smoking and then limit your alcohol consumption. These are the codes for peptic ulcer disease. Lots of codes. And then later on, Appendix B has the codes for the gastric ulcers. So they kind of break them up into two different coding categories. Okay. So moving on to my patient. I found her at Armstrong County Memorial Hospital. I was there from October to December, and she was in twice in November. 36-year-old female, 5 feet. Whenever I saw her, she looked very miserable. She was in a lot of pain from these ulcers. She was diagnosed 6 years ago. Also had fibromyalgia and endometriosis, which does not help with the pain, of course. So she's just in a lot of pain constantly. Got very poor appetite, and she actually was negative for the H. pylori virus, which is interesting. Here's just a little description. I should put this in earlier. The peptic ulcer disease, you can see where the ulcers are. You can see the duodenum ulcer, or duodenal ulcers further down, and then she had the 2 gastric ulcers. So it would have been up here in this part of the stomach, and then you can see the different linings, like how it would affect the linings of the stomach. It was interesting to find out that the gastric ulcers, the symptoms do not follow a consistent pattern. Whereas, it's kind of just like the pain, it could be relieved from eating, it could not, it kind of depends. And then duodenal ulcers are more consistent. So if the pain won't be there when the patient first awakens, but then they'll appear mid-morning. And then after they eat, it'll usually relieve the pain, but then it'll come back 2 to 3 hours later. So also it's interesting because the gastric ulcers are less common, and then duodenal ulcers usually affect people from 30 to 50 years old. So she was kind of strange. It was weird that she would have gastric ulcers, and then gastrics are more common in people 60 years and older. So I found that a little bit interesting. Okay, this is her anthropometric and biochemical measures. I actually have 2 lab values. I have it from her first admit or second admit. She's 5 feet tall. She kind of fluctuated, 99 pounds to 105. Her usual body weight was 135, so she lost a ton of weight from all these ulcers, the complications and the pain, and just simply not eating. So her BMI was 20.1. Even with her current weight, she's a little bit above the percent ideal body weight. And then you can just see some of her lab values. Okay, so she had an endoscopy that revealed the 2 peptic ulcers, the gastric ones. That was done in the hospital. Her medications, so she's well aware after being diagnosed 6 years ago not to take the NSAIDs, but her favorite medication to take is the aspirin. So she continues to take it, help with the pain. It's kind of like a catch-22. She'll take it, feel better, and then she'll have a flare-up, or it won't help her in the long run. So it was unfortunate that she just kind of kept doing that and kind of making her condition worse. So she was on Prilosec, and she had a couple home remedies such as hot baths. She told me, I think it was the first admission, she would be in the bath for up to 23 hours of the day sometimes, just with the pain being so bad. And she'd use heating pads mostly on her back, and didn't take any vitamin or herbal supplements. Disease risks, these are a couple of disease risks that you could be more at chance of getting: colon cancer, GERD, gastritis, stomach cancer, dyslexia, autism, and of course the doctors, their follow-up was stop using the NSAID, stop using the aspirin, Advil, whatever she likes to take, and to follow low fat and a caffeine-free diet. For her socioeconomic history, she's divorced, she has 4 children. I believe they're all of the teenage years, so of course they don't help with the stress. I think they're not real helpful. They kind of make it worse. She's unemployed, and she has I think a significant other boyfriend. Someone was in the room. He mostly cooks for her, but didn't really find out all the details of the situation. Okay, so for her diet history, when she was having a flare-up, she literally won't eat anything. She would tell me she hadn't eaten for several days prior to coming in, and she reported a 20-pound weight loss over I think it was 2 months. Just losing a ton of weight from not eating. Very bland foods, no seasonings. The boyfriend or significant other would just cook very basic foods like chicken, Alfredo noodles, and then he reported that he would make them and she wouldn't even eat them, so he complained about that. and then drinking tons of milk. That was another thing that she would do to help with her pain. And then of course that's again, it'll help at the time, it'll help kind of coat it, but then it'll in turn like later on produce more acid. So it'll kind of upset the ulcers more. So she will, again, sometimes in order to eat, she would take like Advil or aspirin, and then she would eat because it would help with the pain, and she'd be able to eat. But she just did lots of things that were not good for her health and didn't really help her in the long run. And she just wasn't a big eater to begin with, not a big snacker. Did not consume alcohol, didn't smoke. So that wasn't an issue for her. Like I said, she was readmitted within 2 months. I saw her both times. Early November and then later on in November she came back. She was admitted 2 different things. Abdominal pain was the second time. The 20-pound weight loss over 2 months. She had lots of abdominal pain, nausea, vomiting, no vomiting blood or bloody stools. The second time she came in, she reported having trouble swallowing, felt like she was swallowing a brick. So that was an interesting find. Chest pain, just in general, just pain all over. When she had a flare-up, she would have the pain all over. And then when she was in the hospital, she was in for her diet with the GI Medical Soft. Her estimated needs, I used her usual body weight, which is 135, and I just had a little bit lower factor. It was the 24 kcal per kilogram. She's only 5 feet, so she's not needing a ton of energy, but just to even get her, just to kind of gain some of that weight back. But again, she's not even close to this based on her not eating for days and days, and maybe snacking a little bit when she could kind of tolerate the pain enough to eat something. And then protein was 61.2 grams per day. And then fluids, which is the normal 1837 milliliters per day. These are some of her lab values. You can see her first admission, her white blood cells were elevated, probably due to inflammation. Everything you can see was like her hemoglobin was off, her hematocrit, they both were low. And then her gastrin was definitely elevated. So that'll show, it can show peptic ulcer disease, kidney failure, it can indicate a couple of different things. And we know that normally is released after eating, so something's off if it's that much higher, then it should be less than 100. And then her second admit, her lab values were a little bit more normal, but you can see her hematocrit and her hemoglobin are still a little bit lower. Her white blood cell value came down some, so it's not elevated anymore, which is probably a good sign, probably not as inflamed. So these are some of her pharmacy, or her active pharmacy orders. We mentioned before the sulforaphate, which was the medication to help with the ulcers. So she was on that when she was first admitted. A couple of these are antidepressive drugs. Some are vitamins, so she had a multivitamin both times. Cymbalta is a antidepressant drug. She was on Percocet, the pain meds. So it kind of varied what she had. And she had some IV fluids just to kind of help with dehydration. So for her assessment, I'm not going to really go into too much because we just kind of went over her lab values, her poor appetite, her weight loss, all of those are factors. So for her diagnosis, I said unintended weight loss related to poor appetite, limited food intake, and dysphagia as evidenced by a patient reporting a 20-pound weight loss over 2 months, just 22.7%. And food and nutrition related knowledge deficit related to the use of NSAIDs and excessive intake of the milk. And then that was evidenced by her lab values. Her gastrin was 136 and her hemoglobin was 9.4. So for the first diagnosis, just some outcome goals, trying to consume like a more regular diet, trying to eat more snacks, like have more of a regular schedule, and have nutrient-rich, like calorie-dense foods. She's not good at eating, she's not a big snacker, so it's hard for her to even get anything in. And then action goals, I recommended having a supplement. It could be like a boost drink, could be carnations for breakfast, just something that she could get down. Maybe having something like a softer foods for dysphagia is present, and then just trying to eat more frequently. It could be small meals, it doesn't have to be anything big. And then for her second one, try not to have these negative behaviors such as drinking tons of milk, and just finding maybe better coping methods such as having the NSAIDs, drinking the milk, the baths. They might be helping at the time, but I feel like she could do, be more productive and trying to find some pain relievers. So first off, just trying to eliminate the Advil, aspirin use, cut her milk back to 2 to 3 cups a day, and just find maybe do some more research, find out what are some other good fixes. Maybe see like a gastroenterologist, see if they can prescribe something for the ulcers, and I also referred her to a dietitian. Learn about some good things to eat that would help. Okay, so monitoring and evaluation. Just follow up with the client, see how her weight's doing, see how her intake is, see if she's actually eating, see how her disease state is going and how she's managing, and then see if she actually followed up with referrals and maybe made appointments to see a gastroenterologist or an RD. And these are the appendix items. This was the diet she was on when she was in the hospital. You can see it was very bland foods, very soft. And then these are the extra codes for the gastric ulcers. Any questions?
When you referred her to a dietitian, like yourself, did you think to include the boyfriend since he's here to do all the cooking?
I didn't think about that, but that would be a good idea because he would probably benefit from hearing about the foods to buy at the grocery store and what to prepare and how to prepare it.
Yeah,
So that would be good.
because often you go into, and it's usually the man you're speaking to, and no one includes the wife, and he takes all your information and throws it in a fire. What does it matter?
That's a good idea. He'd be good to have come as well.
Yeah.
Couple of questions, and it really has to do with the primary problem. I think it's probably fibromyalgia.
I think
That's really, and she would have pain. The other is I'm curious as to why thiamine was started in her first admission. Is alcohol not a factor in her life?
There was no note of any alcohol use at all, so I wasn't sure about that
Could
one.
be the nerve pain, taking time.
Yeah, and this Involta can be before the pain, or it could be an antidepressant, and I'm not hearing anything here. If she's in chronic pain, would she be depressed? Yeah.
Yeah.
And the other part was, it appeared to me that she may have had a yeast infection of some kind, because that's what the fluconazole would be, Vicodin, which would account for, if it was in her mouth, her difficulty swallowing. If she was on antibiotics for some point, those are questions in my mind.
Yes.
Any bells to you?
I did notice that the one was, antifungal, and I was questioning that. I'm not too sure. I tried looking through some charting, and I didn't find any notice of it. It's probably, I'm sure.
Controlling it, look at SNR, something's not right.
Something's not right.
Was anyone concerned that her hemoglobin dropped dramatically? Maybe not dramatically. I'm dramatic.
Yeah.
It's a little bit, did they look for bleeding?
There's no bleeding, no vomiting blood, no bloody stools. I guess they were keeping track of it, but it was a dramatic drop.
That girl's gotta stop taking that aspirin stuff. Alka-Seltzer, all that other stuff.
Why would they want her to limit the milk?
Milk, because that would, so it would coat originally, but then it would cause more acid. And your stomach would release more acid.
There's still another reason too. Think about it in regards to pain. What does milk, what's the one mineral that milk has a lot of that's related to pain transmission? Start with a C.
Calcium.
And so that's why they've taken out away from many people with ulcers or with pain, because the calcium stimulates the nerves and then the pain is worse. You know, a down and dirty way of kind of diagnosing between in your mind between cancer of the stomach and gastric ulcers in relation to food.
No, Linda, what is it?
What does food normally do if you have an ulcer and you eat? What happens to your pain? It usually goes down, right?
I guess it depends on the ulcer, right? It would-
Yeah, but generally.
Generally.
And if you have cancer of the stomach and you take food, what happens to the pain?
Go up.
So that's just a very quick way. Back in the old days, that's the way we used to determine it to make a diagnosis. And then what's one other medication? I don't see it down here, but what should you always warn people that have ulcers about? About taking a medication that's very, very ulcer producing. And they may put her on it because of her pain. So why would it be? Yes, somebody said, your friend's over there trying to. Prednisone.
Oh, it's a steroid, yeah.
Yes, because they are so quick, and if people have pain, a lot of times they'll say, well, I know you shouldn't do this, but. Good job.
Sorry, maybe someone knows this, but under the disease risk, there's autism. Do you know the link between
I
those two?
don't really know the link. I found that it was a risk factor, but I'm not sure directly how they linked. Yeah, that's a good answer. Thank you.
And last but not least.
I know, well, I hope I'm not least, but, yeah.
I said last but not least.
Okay, that's good. So I'm last. My name is Stacy, for all of you that don't know me, and I'm talking about COPD. So I'm going to go over the overview of COPD. COPD stands for the chronic obstructive pulmonary disease. And this is just an umbrella term for the disease state because there's many different forms that can go under it, such as chronic bronchitis. The chronic bronchitis would, you would hear pink puffers or blue bloaters. The bronchitis would be the blue bloater. And these people have the inflammation and the mucus formed in the airway passages. And a lot of people assume that blue bloaters are heavier than pink puffers because they're on steroid uses to decrease the inflammation in the passages. And then there's the emphysema, which they are the pink puffers, and they are the thinner people because they have so much extra work to breathe. And so a lot of people associate pink puffers with thinner. And that is an enlargement of the air spaces shown in the picture. And that eliminates some of the surface area for gas exchanges. So it's based on structure changes in the lungs that cause these disease. So which I'll talk about here is you have to have that irritant, that stimuli. So most people, the greatest risk is smoking. Some things also could be if you worked in like a mill or in a bad, or firemen that work with heavy smoke. But the number one risk is, the number one irritant is cigarette smoke. So basically the cigarette smokes releases the inflammatory cells, and then those inflammatory cells have a cascade which release the inflammatory mediators, and the chronic inflammation over time makes those inflammatory cells change the structure in the lungs, like the inflammation from bronchitis and the air sacs to be built and enlarge. So that chronic inflammation over time from the stimulant creates these structural changes. And this kind of just shows the picture that depicts the structural changes. It goes, it has the inflammatory cells, and then below the release of the mucus and the structure change in the lung. So some main symptoms of COPD. So it's dyspnea, it's the shortness of breath, obviously, that you see. Persistent cough. This cough can last a really long time. A lot of people